talk is pancreas cancer screening, am I a candidate, and review of the guidelines. All right, great. Here are my disclosures. Again, they haven't changed. Here's the outline of my talk. We'll talk about pancreas cancer screening guidelines, does pancreas cancer screening work, and future directions. So pancreas cancer. So here are the estimates for 2023. So 64,050 people will be diagnosed with pancreas cancer this year in the United States, 3% of all cancers. And in men and women, here are the cancer incidence estimates for this year. And you'll see that for men, it's 10th on the list. For women, it's 8th on the list for incidence. However, when you look at deaths related to the cancer, pancreas cancer is 4th on both lists. It follows lung, prostate, colon in men, and lung, breast, colon in women. Collectively, 50,550 people will die from pancreas cancer this year, 7% of all cancer-related deaths, which will make it the 3rd most common cause of cancer-related death in the US. By 2030, it's projected to be the 2nd most common cause, right? So it's moving up. And certainly a lot of this is due to the fact that while the incidence is fairly low, the mortality rate is very high. If you look at the trend in US cancer deaths in men, you can see how over 1930 to 2020, lung cancer has gone down, prostate cancer has gone down, colon cancer has gone down, pancreas cancer has gone up slowly. And similarly with women, most cancers are trending downwards with relation to US cancer-related deaths. Pancreas cancer is slowly on the rise. And the incidence has increased about 1% per year since the 1990s, thought to be related to obesity and the obesity epidemic. Prognosis, these are data from the American Cancer Society. The 5-year survival is poor for pancreas cancer. Take into account that the American Cancer Society data includes neuroendocrine tumors as part of pancreas cancer. So these estimates, these numbers are probably overestimated for pancreas adenocarcinoma, but the 5-year survival is 12%. The 5-year survival by stage, local cancer at 44%, 15% for regional cancer, and 3% for distant metastases at 5-year survival. And again, I would say that a lot of this is overestimated by the fact that patients with neuroendocrine tumors tend to have a better prognosis. So let's talk about pancreas cancer screening. So the goals of screening is obviously to detect early localized pancreas cancer. You want to stage T1, N0, M0, meaning the tumor is 1 less than 2 centimeters localized to within the pancreas, no lymph node metastases, no metastatic disease anywhere else in the body. The other goal is to detect precursor lesions to pancreas cancer. So we know of a couple. One is the Panin-3 lesion, so the pancreatic intraepithelial neoplasia. So much like other cancers, the precursors are Panin-1, 2, 3, and then pancreas adenocarcinoma. Panin-3 is considered the precursor to pancreas cancer. Or removing cystic lesions with high-grade dysplasia, which again would be concerning for the eventual development of pancreas cancer. And ultimately, the goal here is to improve mortality in these patients. There are plenty of guidelines that are out there. The USPSTF, the National Comprehensive Cancer Network, our GI societies, including the AGA and the ASGE, have guidelines out there, and then the CAPS study group. The USPSTF recommends against screening for pancreas cancer in the general population, and it gives it a grade D. And I think everyone agrees that pancreas cancer screening should not be offered to everyone in the general population like we do for, say, breast cancer or colon cancer. Breast cancer for women, of course. So the USPSTF guidelines are not very helpful with regards to pancreas cancer screening. And of the others, I'd say the one set of guidelines that I tend to use are the National Comprehensive Cancer Network guidelines. These guidelines differ in little ways, meaning the eligibility criteria are a little bit different between the different guidelines, but I find that the NCCN guidelines are most adopted by a lot of our oncology colleagues, our surgical oncologist colleagues, as well as maybe more importantly, the insurance companies. So pancreas cancer screening, there are a lot of questions that come up. Who should be screened? When should screening begin? What tests should we be using for screening? How often should it take place? And the risks and benefits of screening. So let's go through these. So who should be screened? So again, the general population, the risk of pancreas cancer is only about 1.5%. Okay, so contrast that with, say, colon cancer, which we're familiar with in GI, lifetime risk about 5 to 6%. And we do screening for colon cancer. So the patients who should be screened for pancreas cancer are those that are deemed to be high-risk individuals with a greater than 5% lifetime risk of pancreas cancer, because that would put it in the same ballpark as, say, colon cancer. The etiology of pancreas cancer is thought to be sporadic in 80-90% of patients, familial risk in 5 to 10%, and genetic syndrome in 3 to 5% of pancreas cancers. So when we screen patients that are high-risk individuals, we're only trying to prevent or detect the 15 to 20% of patients who may have a familial or genetic syndrome. It's going to be very hard to prevent or detect early cancer in the general population who get sporadic cancers. So who should be screened? Here are a list of the pathogenic germline mutations in the pancreas cancer gene. So any of these patients who have these types of mutations are eligible candidates, as long as they also have a family history of pancreas cancer in a first or second degree relative from the same side of the family as the mutation. So outside of the CDKN2A and the STK11 mutations, which do not require a family history to get screened, the other mutations require a family history, at least for the NCCN guidelines, okay? So I have plenty of patients who are referred with BRCA1 or BRCA2. They're recently diagnosed with breast cancer, or a family member was, they get tested, they turn out to be positive, but there's no family history of pancreas cancer in that family. We typically can't screen these patients for pancreas cancer, okay? Again, some of the other society guidelines suggest that BRCA1 or BRCA2 alone is enough to screen, but again, we run into issues with insurance coverage covering screening unless they have a family history of pancreas cancer, right? The other situation is if you don't have a mutation, you have multiple family members with pancreas cancer, you can qualify for screening if you're number 2. You have greater than or equal to 2 first-degree relatives with pancreas cancer from the same side of the family, or 3, greater than 3 first and or second-degree relatives with pancreas cancer from the same side of the family. The other question that comes up is, oh, my father got diagnosed with pancreas cancer. I want to get screened for pancreas cancer. Can I get it done? And the answer is no, because having one family member, one first-degree relative with pancreas cancer alone is not an eligible criteria for pancreas cancer screening. Okay. Now, if your sibling, your father's uncle or aunt, multiple family members on that same side of the family get pancreas cancer, then yes, you become eligible. But having one parent or one sibling get pancreas cancer is not enough to qualify, at least based on the current guidelines. When should screening begin? So depending on the mutation, it may change. For most patients, screening starts at age 50. And that's because most familial cancers or pancreas cancers related to genetic mutations, the average age of diagnosis is in the mid to late 60s, 67 years of age. So we start at age 50, which gives us plenty of time potentially to detect a precursor lesion. If you have the STK11 mutation, you start at 30 to 35 years of age, and then the CKDN2A mutation starts at 40 years of age. And that's just because the risk of these patients getting pancreas cancer are higher at a younger age. What test should we use? So we use an MRCP, which is an MRI with a specific timing to look at the pancreas more carefully, or an endoscopic ultrasound, in which case we can perform an FNA to make a tissue diagnosis of a potential lesion. So endoscopic ultrasound, it combines endoscopy with ultrasound that allows visualization through the wall of the GI tract at the pancreas, and it's able to biopsy or sample lesions. I think this seems pretty evident for a lot of people in GI, but I've had physicians, gastroenterologists ask me, oh, there's something in the tail of the pancreas. Can you see that? Or something in the uncinate pancreas. Can you reach that? And yes, we can, right? We can see the entire pancreas on endoscopic ultrasound. So you see, if you get a CT scan, there's something concerning in the pancreas, we should be able to reach it with this endoscopic ultrasound procedure outside of, say, altered anatomy from prior surgery. How often should screening take place? Right now, the guidelines suggest annually, so once a year, and you alternate between the MRI, the endoscopic ultrasound, and you go back and forth, right? So an MRI one year, the EUS the next year, the MRI the following year, and so on. Now, there's some risks associated with screening, right? With MRI, contrast injection, particularly those patients who have chronic kidney disease. There's always concern that you're going to find incidental findings that are benign, that go after, that lead to a goose hunt, looking for things that may not be clinically relevant. With EUS, small risk of bleeding, infection, perforation. It is an invasive procedure requiring anesthesia. If you perform an FNA of, say, a benign lesion or even a malignancy, there's a small risk of pancreatitis associated with the FNA. And otherwise, the other risk that we should consider in patients who are being screened for pancreas cancer is surgery. So patients may undergo a Whipple surgery or a distal pancreatectomy. This picture here shows what a Whipple anatomy looks like after surgery of a pancreas head mass. And there's morbidity and mortality of surgery with uncertain benefit. So if you're in a screening program and say you develop a suspicious lesion that turns out to be atypical on an endoscopic ultrasound FNA, and you have a conversation with the patient about should you undergo surgery or not for this suspicious lesion, many patients will say, I'll like to go to surgery. I'm a high-risk patient. I've had multiple family members, have this condition. I don't want to die from pancreas cancer. Take it out. And you get surgery, and you find out that the lesion is either benign, it was a low-risk lesion, say it was low-grade dysplasia, or say a Panin 1 or 2, or you find out that the cancer is actually already metastatic. The surgery has no clinical benefit to the patient because it's already metastasized to, say, local lymph nodes or even further to other parts of the body. And certainly if you didn't have pancreas cancer screening, you never would have undergone the surgery. So these are the risks that we talk to the patients about when they undergo pancreas cancer screening or decide if they want to go under pancreas cancer screening. But what's the potential benefit? This is the Kaplan-Meier curve, a paper from Canto at Hopkins of her group, where she follows a lot of high-risk individuals. And basically, without going into a lot of detail, the Kaplan-Meier curve shows that for patients who have high-risk lesions, they tend to live longer if they're under surveillance. So the line in yellow here are patients who had not cancer but high-risk lesions. This is out 15, 16 years now. The line in purple in the middle are cancers that were detected during surveillance or during this pancreas cancer screening program. They tend to live right out to 12 years here in some of these patients. And then the group of patients who got pancreas cancer diagnosed outside of surveillance, so they were in this program but didn't come every year, they missed a few years, they ended up getting cancer and doing much worse. So obviously the benefit here is to try to improve mortality in this high-risk patient population. So screening improves survival was the point of this article. So does pancreas cancer screening work? Well, let's look at the evidence. So I'm just going to touch on a couple papers because there's a lot of evidence out there. I'll start with this CAPS registry. This is the data from 1998 to 2022, right? That's 24 years of follow-up, 1,461 patients. That's a lot of patients. And in this cohort, there were 10 patients who developed cancer. So first to understand is it takes a lot of patients to screen for high risk to find a cancer, okay? The number needed to treat is somewhere in the 100, 135 range or so based on some data. So there's a lot of patients being followed for a long time in a high-risk group with a very small number of cancers. But let's see how they did, right? So here are the patients, and here's a stage at diagnosis. So in this group of 10 patients that were diagnosed with adenocarcinoma during their screening, 7 were in stage 1, 1 was in stage 2, 1 was in stage 3, and 1 was stage 4. And the one in stage 4 is in red with an asterisk because this one developed metastatic cancer 4 years after the last screening test. So this patient got lost to follow-up, came back, and was diagnosed with metastatic cancer. But the other 9 patients in this cohort who followed and did everything they were supposed to be doing, 7 of the 9 had stage 1 pancreas cancer. The 5-year survival was 73%, and the median survival was 9.8 years. So this seems very promising. 8 additional patients underwent surgery in this cohort. 3 had high-grade dysplasia, which would be considered a success, right? They had a high-risk precursor lesion, but 5 had low-grade dysplasia, which per strictly the guidelines and the goals of pancreas cancer screening, you would argue that these patients underwent surgery unnecessarily. And the conclusion from this study was most pancreas cancers diagnosed within a pancreas cancer screening program have stage 1 disease with long-term survival. And this would certainly support the idea of doing pancreas cancer screening in this high-risk patient population. However, there's another paper that came out just last year in 2022 in Gastroenterology. This was a retrospective study of 2,552 patients. Again, a lot of patients undergoing surveillance or screening with pancreas cancer, for pancreas cancer, and over a 20-year period of time, or from 16 centers, and here's their data. So of their 2,500 patients, they had 28 cancers, okay, followed for 20 years. So again, a lot of people being followed for a small number of cancers that are trying to be detected early. So the data in this group, of the 28 patients who developed cancer, 13 patients developed cancer with a new lesion, meaning the year before there was nothing, and A year afterwards, when they showed up for the next screening test, there was a cancer in 13 of the 28 patients who were diagnosed. 15 of the 28 had a precursor lesion, meaning they had a cyst, some sort of small lesion that was suspicious, but there was something detected on the previous imaging study that was done that then progressed into a cancer over the course of the year. What is surprising, however, though, is that of the 13 patients who developed cancer de novo from the previous imaging study, 10 of the 13 had tumor progression outside of the pancreas in a year. Right? So they look back at the previous MRI, endoscopic ultrasound, no tumor, no mass, nothing seen. And over the course of a year, 10 out of the 13 had cancer outside of the pancreas already. Of the 15 patients who had precursor lesion, 11 of the 15 had tumor progression outside of the pancreas. All right, so these are patients who are in the screening program doing everything they're supposed to be doing, coming back every year, and despite that, there's pancreas cancers being diagnosed that are outside of the pancreas. So their conclusions were, no prior lesion was seen in nearly half of high-risk individuals who develop pancreas cancer, most with an advanced stage, and rapid neoplastic progression can occur in previously detectable lesions. A little scary to think about. And their suggestion, of course, was that more sensitive diagnostic tools or different management strategy is needed to detect the development of pancreas cancer. And certainly based on this data, one would have to agree with their conclusion here. I'll end with this, the future directions for pancreas cancer screening. Look, I think this IMMray PanKD, the first blood test for the early detection of pancreas cancer, came out last year and is now commercially available. It's a proprietary novel biomarker signature for stage 1 and stage 2 cancers. It looks at 9 different biomarkers in the blood. The sensitivity is 89%, specificity of 99% for detecting stage 1 and stage 2 pancreas cancer. Seems very promising. Obviously, there's a lot of potential benefits here. It's convenient. It's a blood test. You go for your annual physical, get a blood test. How easy is that, right? Patient access. People don't have access to MRIs or endoscopic ultrasounds all over the country. So getting a blood test would be very simple and easy. It's a potential interval testing modality. So maybe in between your annual EUS and MRI, you get a blood test. It would seem a reasonable way to continue screening with shorter intervals. And an additional diagnostic tool, right? So in addition to imaging, now you got this potential blood test to help you detect pancreas cancer at an early stage. But what's to be determined? So it's not currently covered by insurance, and the out-of-pocket costs range between $0 to $746 based on household income, right? So they have a sliding scale depending on how much you make will determine how much you need to pay for this test. And it's not a one-time test. So if you get this test when you're 50 years old, it doesn't mean, oh, you're negative, you're good to go for the rest of your life. You potentially have to get this test done, say every year or every other year, depending on what we decide to do with this test. That can be a lot of out-of-pocket costs for anyone. So it's unclear when and how often to test this, right? We test every year, every 6 months. And then what do you do with a positive test result with negative imaging? So say you get a positive test. This blood test would be so good, so specific at detecting pancreas cancer, and then you get an MRI or an endoscopic ultrasound and we can't find it. Then what do you do? Right? What are we going to do with that result, this positive result with now potentially a negative imaging study? How are you going to manage this patient? You can't just go and take the whole pancreas out. Do we bring these patients back for repeated imaging every couple of months? So I think there's still some questions to be determined on how to manage this blood test, but I think it's a step in the right direction for sure. The other is radiomics. So this essentially is AI in the field of radiology, and they use mathematical quantifications of imaging features that are beyond our human perception at looking at, take in this case, CT scans. So here's a study that was published in Gastroenterology last year. It was a case control study, 155 patients with pre-diagnostic CT scans, and another cohort, age-matched, 265 patients with a normal pancreas. And so they looked at the ability of this AI model to detect pancreas cancer on pre-diagnostic CT scans that were done 3 to 36 months prior to a pancreas cancer diagnosis. So this cohort of 155 patients had a CT scan 3 months to 3 years before their diagnosis of pancreas cancer. Go back and look at those CT scans. Was there anything there that would have helped them figure out that there was actually a cancer back then, as opposed to when they finally got diagnosed? And so here's just an example of a patient who had this done in the study. It's all retrospective. Panels A and B are the normal pancreas that we're seeing in a 75-year-old man. And then 2.5 years later, in panel C, there's a mass in the body of the pancreas. And they went back and they laid this AI model on top of the old original scans from 2.5 years ago. And they looked at this thing, and I'm not sure about the details, but essentially they were detecting lesions that were concerning for pancreas cancer 3 months to 3 years before the diagnosis. So the results were that this computer-generated model was able to detect pancreas cancer from compared to a normal pancreas at substantial lead time before the clinical diagnosis. And the lead time in these patients were anywhere between 93 to 1,092 days, the median of about a year, right? So this AI model was able to detect kind of an early precursor lesion well in advance of when it showed up relative to what a radiologist could see and identify. The sensitivity of this model was 95%, and the specificity was 90%, and the computer was better than 2 experienced radiologists who they had go back and look at these CT scans and say, do you see anything suspicious on these scans? And in many cases, they did not. So in conclusion, pancreas cancer screening is only indicated for high-risk individuals with a lifetime risk greater than 5%. We went over some of that criteria today. The potential risks and benefits of pancreas cancer screening should be discussed prior to anyone enrolling in this study, in a program like this. Alternating annual EUS and MRI is currently recommended, but evidence suggests that there may be room for further improvement. And better biomarkers and improved image interpretation may improve early detection and diagnosis of pancreas cancer. Thank you.